Unit 4, Methods and Techniques for Peripheral IV Therapy. The first thing we're going to cover is documentation. Documentation can serve as an accurate description of care, also as legal protection if you're ever drug into court if something went wrong with the patient's IV. Let's say, for example, even though you did have a patient with continuous IV flowing and you checked on that IV site, you checked on that the solution was correct, you checked that the rate was correct, and let's say you did everything right, but you didn't document it, and then something happens with that IV. Let's say it infiltrated and the patient ended up having to have a finger amputated because the solution was irritating and caused necrosis. If you didn't have that documentation done, you know the saying, if it wasn't documented, it wasn't done. It can also serve as a mechanism for recording and retrieving information. Let's say you want to check when the last time that IV was changed, or the dressing was changed, or if there were any issues, how the patient responded with that IV start. It also is a record for insurers and equipment supplies used. IV equipment does cost money, and you have to have a way to keep track, whether it's stickers on the equipment you use that you pull off and put with a patient's chart or charge card, or whether it's submitted to insurance to cover those costs. So documentation, as with anything with nursing, is of the utmost importance. Some things that you're going to be documenting, and we'll talk about the different things you'll be documenting with the peripheral IV starts, with dressing changes, tubing changes. The main thing to remember are the things you're going to be documenting with the initiation of a peripheral IV or an IV lock. The first thing you're going to make sure that you document is obviously the size, length, and type of device. I'm just going to throw out one. Let's say it was a 24-gauge Gelco, and Gelco is just a name brand. I might say then 24-gauge and 3/4 inch Gelco when I talk about the size, length, and type of device. I'm going to definitely be documenting at the end of my note my name and my credentials, the date and time, as well as the site location. Best, if you can, to use anatomical vein name preferred of which vein you used, just in case if there is any description. It also serves, like we said previous, as retrieving information. Let's say I want to look to see where other IVs were started previously on this patient with that hospital stay. I can go back and look at that. The type of dressing used, did you use gauze, did you use Tegaderm? Condition of the site, prior and after. Does the site look good with no drainage? Is it warm? Is it cold? What is the color? Is it pink? The type of solution, flushed with 5 mils of normal saline. That's also important, as well as if there's any additives. Let's say that the RN is going to be hooking up the first bag of, let's say, normal saline with 20 milliequivalents of potassium. You'd be documenting that. Other things I would document is that flow rate if I have that continuous bag going. And I'll give you an example here in a minute. I'm also going to document if there's a use of electronic infusion device, if it's hooked up to the pump, or it's hooked up to gravity. Any complications. Did the patient move? Did the patient pass out? Did the patient get faint? As well as any nursing interventions that I did. Let's say patient states feeling lightheaded while sitting during IV insertion. So then my intervention might be to place that patient's head down, the head of the bed down, maybe get a cold washcloth on their head, distraction. I would try to do things that would help that, as well as document those interventions to show that I did respond to what was going on with the patient. The next thing is very important. With any type of education that we do with our patients, it's important that we document this education, as well as, and equally important, the patient's understanding of this education. And that could be as simple as patient states, yes, I understand, or patient return demonstrated skill or whatever that you were teaching that patient. There's so much that we teach our patients during a shift that unfortunately we just don't take the time to document all the education. And the education doesn't have to be formal. It could just be you walk in and the patient has a question, so you educate them. Maybe you educate them on the call light, or you educate them on their condition or their disease or their diagnosis of why they're in the hospital. So always important that we do educate the patient, and that's always going to be part of our first step when we do something new with the patient, whether it is initiating an IV or hanging an antibiotic or let's say just a continuous infusion of normal saline. We're always going to be educating that patient before we actually do something, especially with the antibiotics. Even if the patient had been receiving 2, 3, 4, 5 doses, it's still good just to let the patient know what you're hanging again if they've had it previous to this day, because those complications or allergic reactions can happen with subsequent doses. So always good to do that education, and of course follow your facility policy. Many facilities do have you as part of their policy whenever a patient does have a new medication that you educate that patient on that medication and document such. Another thing that we're going to document is how many attempts. IV inserted in 1 attempt, IV inserted on a 3rd attempt, that type of thing. We're going to document how many attempts. This again is going to help provide that legal protection in the event a complication does happen with the IV. Obviously your patient, if they're in their if they are in the hospital, many times they're scared, they're worried, they're nervous, and their perception of what's going on isn't always an accurate picture of what happened. So that documentation, again, is going to be what saves you. Some other things in addition to documentation is we're going to be labeling that dressing. We're going to be labeling, after we start that IV, on the dressing. And in the skills lab, we'll show you the Tegaderms. If you're not familiar with them, they do have a little sticker that you can write in the date and time, as well as your initials and credentials to put on that. That way, at first glance, so you're coming on shift, you can eyeball to see when that IV was initiated or when the dressing was changed. So not only are you documenting it in the notes or whatever flow sheet you use for your facility policy or computer, you're still labeling that dressing with the date and time and your initials. According to your facility policy, you may be labeling the IV tubing as well as the IV bag. I think it's very, very important with the IV tubing that tubing is labeled. There are special stickers you can get that you just put the date and time that you change that tubing. Certain facilities may have every Monday, Wednesday, Friday is a tubing change. They have different standards as far as if you have a secondary tubing, of how often that needs to be changed, as well as your primary tubing. So make sure you follow your facility policy on that. When you do come on your shift, if you don't have that sticker to know when that last IV tubing was changed, that does require time on your part to have to go back and look when that IV was started. And if that patient had been there for, let's say, 7 to 10 days, it might take a while for you to figure out of when that tubing was changed and when it needs to be changed. That can be a source of a potential infection risk for that patient if you do not get that tubing changed within the recommended time frame. And again, label every time with every dressing change that you do for peripheral IVs as well as midlines and PICC lines. Some labeling that you might do on the, let's say on your IV bag, excuse me, might be the date and time that you spiked it. I have seen some people also take a permanent marker and mark on the line at the end of their shift to calculate INO, as well as the beginning of their shift, so they can measure that. Maybe they mark at the 800 line with the time and date that they started their shift, let's say 7 a.m., and then they ended, let's say, at 3 p.m. They mark down at the 100 line with the date and time. So that way they can eyeball it quickly to see, especially if there's no pump to clear, and to calculate that for you, that you can see an eyeball just to make sure that the patient got the ordered amount of solution that they were supposed to, as well as completing your documentation of intake for that patient, as the IV fluids are included in this intake. Some other things that you're going to document for IV therapy maintenance, and this is, let's say, an IV that's already been established, and so you're monitoring it throughout your shift, is you're going to always be looking at the condition of the site. Even if this IV does not have a continuous flow, it is still good if it's, let's say, locked off, to look at it at least every few hours just to make sure it looks okay. Most facilities will have you flushing IV locks every 8 hours. And if your hospital, like for example, a facility might have it at 6, 2, and 10, definitely those are times you're going to be looking at the sites, but it's still good just to keep an eyeball in between on that. Now, obviously, if they do have IV fluid running continuously, it is good standard practice to be looking at that IV site every hour. In the middle of the night, if you're a night shift worker, you can bring a flashlight in. Definitely tell your patient before they go to bed that, they might want to try to leave their hand outside the blanket if they can, or off their side, and that you'll be coming in every hour to check that to make sure that it looks okay. So you're going to be looking at the condition of the site. That's why it's important to have a transparent dressing over it so you can visualize it clear. But you can also tell if there's any drainage. Maybe if the IV catheter is moved a little bit, you might have some backflow of the saline with a little blood tinge coming out of the insertion site. So you're looking for those things. You're also looking for any signs of infiltration or swelling, any type of reaction, maybe a redness or a red streak that you see going up the patient's arm from their site. Also going to be documenting any site care provided. Let's say there was some drainage from that IV site, or the catheter did come out a little bit from the skin. If you're able to try to keep that IV, you might be able to manipulate it and push it back in. But it's important anytime that dressing does get wet or it starts to roll up, or let's say a patient bumped it and that IV site is not secure, that you do the dressing changes on that, change another dressing. You don't have to wait for the 7 days or what have you of what your facility mandates. You can go ahead and change that. But definitely document that again in your nurse's notes. Anytime you do any tubing or solution changes as well, document those per your facility policies. Any and all ongoing teaching of your patient, again, you're going to document. Anytime you flush it, you're going to document why you're flushing, as well as obviously teaching your patient of why you're flushing it, as well as, again, their understanding of the teaching. Not only are you going to be documenting when you start an IV, but you're also going to be documenting when you discontinue IV therapy, as well as that IV catheter. So again, it's the same thing. You're going to have the date and time, reason for discontinuing, doctor ordered IV to be deseed. You're going to look at the site before and after the device is removed and document any findings you have with that. Any complications or patient reactions, again, with the discontinuing. When you take the IV catheter out, it's very important that you do have some gauze, or you do have a cotton ball or something that you can apply pressure to the IV site. It's not always going to bleed, but at times it will bleed, and it's important that you are applying pressure. And you might even educate the patient on why you're applying pressure, have them apply pressure. I can think of a situation when I DC'd, especially kiddos, but even though I had applied pressure after I DC'd that IV site and put a Band-Aid on it, I would still tell the parent, if you see the blood seeping through on the Band-Aid, go ahead and just put some pressure on that to help that blood clot a little bit to stop that from bleeding. Obviously, again, I'm going to document any nursing interventions that I've done with that patient. When I remove the catheter, it's very important that I inspect the catheter as well as the catheter tip to see if if the tip might have broken off, or if there was anything wrong with the tip. Very, very, very important that I document that, as well as let the doctor know, because if something did happen where there is a piece of the tip still lodged in that patient, we might need to do something else further, because that just puts them, again, at a high risk for infection and complications. So anything I do, I'm going to document if there's anything out of the ordinary, depending what you document. If you document by exception, follow your facility policy. Your facility policy also might have something in place that if the IV insertion site is showing signs of infection, such as maybe redness, it feels warm, or if you have some yellow drainage, things are out of the ordinary. I worked at places where they automatically will just culture that tip of that IV, as well as take uh, like a Q-tip or what have you to try to culture some of that drainage to see if there is an infection present. So follow your facility policies on what to do if there is any reason to believe that there is an infection. We're also going to be documenting the amount of fluids infused that patient had on their total hospital or facility stay. And that could be in a variety of places, again, according to your IV policy at your facility. So after we've seen the order and the RN has delegated the task to starting the IV, we are going to get started. Some of the things we're going to do before we get started is we're going to talk to the patient about their past experience and ask them, have you had an IV before? We had talked about in previous units that if a patient is upset or if they're nervous or they're anxious, that could cause a lot of vessel constriction and make the IV starting process a lot harder. So you want to have a relaxed patient. You want to have a patient that is not going to look at this as a bad experience. I don't know anybody who says it's a good experience having an IV, but you definitely don't want to scar them for the rest of your life and be that one nurse that they always talk about in future hospital stays and IV starts. So you want to ask them, again, have you had an IV before? And if they say no, then discuss what it is. Many people are just through their basic knowledge think that that needle that you use to introduce the catheter into the blood vessel stays in the vein. So many times, depending on your facility, of course, you don't want to be wasteful, but if you have an extra catheter where the needle has been disengaged, show them that catheter. Obviously use educational and age-appropriate language. When I worked with kids, I referred to that plastic catheter sheath as a straw, and that it's your body using the straw to drink that IV fluid coming from that bag. So, and again, you want to use those terms and the words that are age-appropriate and educational level appropriate for your patient. So then I'm going to describe the procedure. I'm going to let the patient know, let's say they're in for dehydration, and say, Dr. So-and-so had ordered you to have some IV fluids, and he wants you to have some normal saline. And I might talk to him about it's just basically like salt water, and the way that we want to get this fluid to you, since you haven't been able to drink, is through vein access. And then I might draw a picture. I might show them exactly what's going to happen. I think it's very important that if the patient is educated and know what's going to happen, they're going to be a little bit more accepting, and it's going to go a lot smoother. So I also might say, Dr. So-and-so wants you to have this IV fluid for the next few days, and then he's going to evaluate your labs just to see that you're hydrated. Obviously, I'm not the one prescribing as a nurse, so I can't say you are going to have this exactly 3 days, but I can relay that information that the doctor has ordered. If they're getting antibiotics, the doctor might have ordered antibiotics times 5 days. Well, I can tell them, well, the doctor's ordered that you'll be getting these antibiotics for 5 days. So at least the patient has an idea of how long they're going to have this fluid. I want to give them as much information as possible as well, such as these are some things that I want you as a patient to report to me. If you're having any discomfort where that IV site is, if you feel any tightness or other adverse reactions, I'm going to ask them to report that to me. There is a little, depending on the medication, some of it might sting. Anything with potassium irritates the vein, and that does sting a little bit. So I might tell the patient what to expect. When I flush this IV, it might feel a little cold, but it should not hurt. And I can gauge by the patient's reaction if I go to flush something, if they flinch, and it's a painful flinch as opposed to, ooh, that was cold type of flinch. So I want to educate them on the things that I want them to report to me. They shouldn't sit there or lay there in discomfort if an IV is going bad just until I discover it. So I want to make sure that I let them know what to expect and what is abnormal. And then again, anything with education that would be considered education, I'm going to have them, I'm going to definitely gauge their understanding and document that understanding, such as patient nodded head and understanding, or patient was able to state back one complication to report to the RN or to the LPN. So that's another way in which you can document the patient understanding. I'm also going to talk to the patient about activity restrictions and to be careful. There's a lot of different things that you can do in the hospital setting that'll help with that IV tubing. I always called it a neti. I'm not sure exactly what the term is for, but I've seen them used sometimes in holding up an arm. They come in a box, and it literally looks kind of like fishnet stockings, but it's like a cotton. I'd use those for the kids to put over for that J-loop or any tubing that might get pulled or dislodged, and that would help hold that down. I want to be very careful with tape. I've seen people that almost have tape around the whole arm holding a tubing down, and that almost acts like a tourniquet. And that right there, if you have an IV, will infiltrate and go bad, as well as cause some major complications. I want to be careful too. I've seen people use and it's almost like an ACE wrap, and again, I apologize, I can't think of the name of it, but it's almost like ACE wrap, but it sticks on itself. I've seen people wrap IVs with that. The bad thing with that is they cover the insertion site. So not only does that occlude or obstruct your view of the IV site every hour, that again too is it could be too tight and you're having to assess circulation, and there are many things that can happen with that. So you have to be very careful with how you go about keeping that IV tubing secure and that IV lock secure. So with the patient, especially if they have an IV in the antecubital and they're hooked up to a pump, if the IV beeps, you might want to educate them, unfortunately it's a good vein, but every time you bend your arm, it clamps off that or kind of occludes that catheter, and so the machine's going to beep. So you might want to talk to the patient about either keeping their arm straight, or that you might even have like a little arm board that you could put on that bend of that elbow to help remind the patient not to bend their elbow. The tricky thing about that, though, is you want to be careful and not get into a situation where the device you use is considered a restraint. So just some things to consider, and again, check with your facility policy. Most facilities will have items in place, or you can ask other nurses on that. In the shower, too, even if the IV is locked off, you still have to cover that IV site. You can't just expose it to the water. So I have seen people put an actual glove over the site. The gloves that we use, I'll see them do that. There's actual little like plastic sack things that are specifically for covering IV sites, and I've seen people tape those. So just some things that you might want to think about. If you have the chance when you start an IV, and let's say both hand veins look good, you might want to ask the patient, are you right or left-handed? And try to pick the hand, if you have that choice, of their non-dominant hand, so that if they do need to write or dial a phone or do whatever, that you can let them keep that dominant hand so that it won't affect any activity restrictions. Before we go to 31, I just wanted to also mention on page 37, just highlights a little bit more about teaching a patient about peripheral IV therapy, such as some terms you can use for describing the procedure, do's and don'ts of what to tell the patient, what not to tell the patient, and the worst, basically that, you don't want to get that patient worked up. I mean, it's a basic procedure. The risks are very minimal compared to the outcomes or the benefits. So definitely let them know that once the device is secure, they'll be able to move around and with a little restriction depending where it's at. So page 37 has some great information. As well as above, they have a little formula. Care plus confidence equals a relaxed, cooperative patient. So, and we talked about this before, if this is your first IV site, on your own, don't tell the patient that. I'm not asking you to lie if the patient straight out asks you, but even if they ask you, be confident. Oh, I have experience, with the preceptor watching or a skills lab, and, don't go in, even though you may be just freaking out on the inside and sweating bullets, don't go in all nervous, fumbling with everything. Take a deep breath. Know you got this. Everybody has their good days. Everybody has their bad days. So the best you can do is go in with confidence, take a deep breath, and do the best you can. And if you don't get it, don't be discouraged. I've seen people who will go weeks and weeks of getting every single IV on the first time, hard sticks, and then all of a sudden miss it one day. And it was a big ropey vein right there in front of them. So, it happens to the best of us. So moving on, page 31 is a review from what we have covered in previous units, but it's a good thing to always review of the purpose of the IV therapy. Main reasons why people receive or have IV therapy ordered is to restore and maintain the fluid and electrolyte balance, provide medications and any chemotherapeutic agents that they may be on, transfuse blood and blood products, as well as deliver TPN and other nutritional supplements. Because remember that total parental nutrition and lipids and other supplements are not able to go through the peripheral IV route. So that's just a good review. Some other things to review are benefits. Obviously, if the patient's NPO, whether it be because of surgery or they're nauseated and they're vomiting, for whatever reason, we can get this patient fluids and nutrition via line. Also allows for more accurate dosing, as well as it allows that medication to reach the bloodstream heck of a lot quicker, and that patient will get that medication basically immediately. The time for a PO pill might be 30 to 45 minutes, where an IV medication is going to be in the next, anywhere depending on medication from 10 seconds to a minute or so. So they're going to have that immediate reaction to it in their body. Some of the risks of IV therapy, and this is also listed on page 31, is obvious blood vessel damage. You're going to be introducing a needle into the blood vessel. If you even just the poke into the blood vessel could do some damage. So very important that when you are starting out, that once you advance that needle, that you're not going in and out, still staying within the vessel, but moving that catheter around or changing angles. You want to be very careful with that because you could be poking and you're damaging. Another complication would be infiltration as well as infection. The patient get an overdose of fluids if you have it to gravity or you don't have the clamp right or there was a machine malfunction, as well as having some complications from incompatibility of drugs or solutions. There are, if you look at your drug book, you'll see there's a little table in most books. I have not seen a drug book without this, but they do have a list of IV solutions that are incompatible with other IV solutions or medications. I've seen this firsthand where literally the solution in the line just started to crystallize. I can't remember right offhand what was added to the solution that was in there, but the nurse literally just ripped that IV out because we didn't want that crystallized solution going into the patient. So very important that you know which medications are incompatible. Some other risks would be adverse or allergic reactions. It does limit the activity of the patient. More specifically, depending on where that IV access is going to determine what activity is limited. It is expensive. All the tubing and everything obviously is more expensive than most medications where it's in a pill. Some other things to consider when you are taking on this expanded role, obviously, is you're going to treat the IV solution the same way with the 6 rights. I know they probably added 7 or 8 now, but when I was in school it was 5 rights, but now the 6th right is documentation. But some of the major lawsuits that occur are over wrong dosage or solution administered to the patient, as well as administering them the incorrect route, something that should have been maybe IV was given IM or what have you. Some other lawsuits included inappropriate placement of catheter, so not putting the catheter in an appropriate place, putting it in a wrong place, as well as failure to monitor. And that failure to monitor doesn't always mean that that nurse did not check on that patient or check on that IV, but that also includes the cases where the nurse just failed to document it. And you could stand on that, or you could sit on that stand all day and the jury could respect you and believe everything you say, but when it comes down to it, if it's not documented, it was not done. So those are some main legal issues that nurses face when dealing with IV therapy. So after we have educated the patient, we explain the procedure to them, we're also going to be checking their medical record. We're going to be looking to see what is their medical history. Do they have a mastectomy on the right side? And we'll talk about it later, and we covered it before of certain sites not to use. What are their allergies? Is the IV fluid or medication that the doctor prescribed, are they allergic to it? Why are they here? What is their current diagnosis? Maybe they have burns or they have congestive heart failure. And if that's the case with congestive heart failure, the last thing we want to do is give them IV fluids and overload them. So we're going to be looking at that, as well as what is their care plan for this stay. I want to definitely review the orders after the RN had delegated the task to me, just to double check. I'm also going to be looking over that patient's lab work. Let's say the doctor ordered normal saline with potassium, and I know you're not going to be hanging that first bag or initiating that first bag, but even if it's your second or third bag, let's say that the doctor ordered normal saline with 40 milliequivalents of potassium to run at 100 mils an hour, and you happen to look, beginning of your shift, at the lab work, the patient had lab drawn, and their potassium is like 4, we're going to be a lot concerned about giving them additional potassium. So we're going to be watching their labs also as part of our monitoring their IV fluid therapy. We're also part of looking at that chart is knowing, as I said before, if they had a mastectomy. If for some reason there are no other sites other than the site of their mastectomy, you have to get physician orders or approval to put an IV in that site. Same thing if, let's say, they're going to dialysis or they have a shunt or fistula. We are not going to be accessing those, and we are not going to put an IV site on that side unless we get that approval from the physician. Same thing with lower extremities, the legs, the feet. Those are not common areas. Now, the exception to that might be on a pediatric floor. Obviously, in kids, I was starting IVs in their feet all the time, as well as the scalp. Now, that is not the case for adults. You do have to get that physician order of approval. Sclerotic veins, same thing too. You want to make sure that if, for whatever reason, the patient's diagnosis or if they've had severe body burns, I mean, there's all kinds of exceptions to this rule, but very important that we do know when to get that physician approval for an out of the normal IV site of preference, including, the hand, the arm. So once we've educated the patient, we looked at their chart, we've got their history, we found our site. Let's say we have a gentleman who's especially hairy. We need to be able to visualize that vein. So when we go to prepare the site, if we have to get rid of some of that hair, whether it be in the arm, the hand, what have you, we are not going to just get the razor out and shave it. If we put any nicks in that skin, and then that's right by our IV site, that is just an extra portal we're giving bacteria to get in that patient's bloodstream. So we're going to use clean scissors, and we're going to cut that hair as close to the skin as we can. And again, we're going to use scissors. We're not going to use the razors for that. We're also going to assess the site of flexion in that area. If we're going with a vein that's on the outside, let's say the thumb or in the wrist, I want to make sure, starting at the top of the hand there, that where that catheter is going to end up is that it's not going to be a spot where that patient, if they move or flex their wrist, that it's going to occlude that catheter. I'm also going to remove any jewelry on that side. That could even be included with the patient's name band or allergy band. But so important that if we do remove that band, that before we remove that band, we have another band there at the bedside ready to be replaced, especially an allergy band. I can't tell you how many times I have seen nurses cut those bands off and then completely forget about putting that band back on that patient, the allergy band and what have you. Whether she got busy with another patient, but always have an extra band, an allergy band with you in case you do need to cut that off. If they're wearing a watch as well, and then we want to educate them why we want to take it off. You know, we don't want that to act as a tourniquet to impede that venous blood flow or impede that IV flow of the fluid into the veins. So educate why we need to have them do them. Same thing with rings. You know, that you might become a little swollen, so you don't want to have to actually cut off a ring just because you didn't take it off prior. Another big thing that I like to ask, and this also kind of ties in with the patient's history, is ask them if they had previous IV sites. Many times patients who have had chemotherapy before, their veins are shot. It's just the agents were very irritating, and so they are a hard stick. So they might be able to tell you, hey, you know what, they never get in my hand. They always have to get anticubital. Listen to your patient with that because your patient's the one who knows best. Also ask them, as well as assessing if you're having to restart an IV especially, you don't want to restart that IV in an area where they did have some phlebitis or infiltration. Again, it's kind of like, think of a hose, and if you got a hole in a hose, and then let's say I go further down, I want to make sure that I start the IV ahead or up above that hole. Otherwise, your IV fluid is just going to infiltrate right in that one spot. So you want to definitely use a different vein if you can when you have to restart IVs. So now that we've got the site ready, we've educated our patient. I kind of went out of order on the slides. We don't have the we would have the equipment at the bedside. But just to review on the tourniquet, you do not want to have that tourniquet so close to that site that you're creating so much pressure that that vein's going to pop the minute that you poke into it. You want to put, rule of thumb is 6 to 12 inches above the intended insertion site. You want to have it tight enough to eliminate all blood flow to that extremity, and you want it tight enough to impede the venous flow but not arterial blood flow. So if you put that puppy on so tight that immediately that patient's hand and arm below turn pale, you want to be very careful with it. You also want to make sure that you are tying that tourniquet in such that you're not tying in a knot, that you have an easy release, and you've got the little, I call bunny ears, up at the top, so it's something that you can quickly release. Because once you get that blood return in that IV catheter, before you disengage the needle and hook up your fluids or your tubing for your lock, you want to undo that tourniquet. Otherwise, you are going to have a flow of blood squirting at you. And usually it takes one time. And after that happens to you and you're having to clean up the patient, change the patient's bed, and have blood on yourself, you'll never do that again. Some things to consider with the elderly, obviously, they're thin as Skinner, just their physiological changes as we age. Sometimes you don't even need a tourniquet with them. Or I've said previous that I might put a tourniquet on just a little bit over their gown. There might be times when you need a blood pressure cuff. And then the question is, well, how far do I pump that cuff up? How do I know? Just inflate it right just below the patient's diastolic pressure. So you might want to take their blood pressure before, or just kind of use a baseline of what their blood pressure has been. But I'm still a big advocate of just getting it prior so you have the actual number at that exact time. You're going to prep the site. Again, according to your facility policy, you're going to use the proper agents to clean the site. Once you clean that site, let it air dry. No fanning the site, no blowing on the site. I can't tell you how annoying it is when I have blood drawn when I see phlebotomists do it. And then you'll see them cut a finger out of their glove so that after they prep the site, they can use that finger to then palpate that vein, which is so crazy because I don't know if they think that glove, once they put it on, it's magical and it sterilizes that finger so that when they cut the hole for their finger to pop out, that finger is not dirty. I've seen people, and this also opens up to nurses. I won't just bang on the phlebotomist, but I'll see them wipe a finger off with an alcohol wipe and then touch that area. So very important if that happens to you, you see it, that you ask them to re-clean the site. Or just due to transmission and universal precautions, you want their full hand, including finger, covered with a glove. So don't feel bad asking for that for yourself, but most definitely always provide it for your patients. So our equipment that we would have gotten previous, obviously I've got catheter with S in the parentheses here. I think it is a good idea to grab a couple catheters. Not saying it's going to take you 2 pokes, and no, it won't jinx you if you bring more than one, but it is good because let's say you take the cap off and you're going to inspect that catheter before you insert it. If there is something that's wrong with it from the manufacturer, at least you know that tourniquet's on, that patient's ready to go. You can just grab another catheter that you brought with you so that you don't have to get up and get extra supplies. Some places will have like a little caddy, an IV caddy, that you can have with extra supplies on it so that you don't have to get a whole bunch and carry it all in. Obviously, alcohol wipes, those are very good, especially if you do have some blood leak outside that site, or if you have some blood, that's a great way to kind of mop up some blood on the patient. Your preps, whether it be a skin prep, if you have a stat lock, package already comes with a skin prep with that. Your dressing, some places may have an IV start kit that is going to have that included with the kit. You might have your Tegaderm, a little, almost kind of like the chucks that you can put that's kind of acts as a barrier, so in case any blood gets dripped on the bed, that kind of protects that. Your J-loop or your lock, if that's going to be the case, your cap, if you're going to lock that off, as well as your flush. And in the skills lab, we'll be walking you through, and you'll get hands-on experience with how to flush and to have that hooked on there. Again, always remember that your flush, your saline flush, is always, according to expanded scope, has to be prepackaged, whether already in a syringe, in a plastic bag, or you can have it prepackaged and labeled from the pharmacist or RN, but it does have to be properly labeled for you to use it. The second thing that you're able to flush with, depending on your facility policy, is if they have heparin. Not all places use heparin. There's a lot of research out there, and just depending on the type of catheters you use is going to dictate as well if you use heparin. That heparin, again, has to be just like the saline, prepackaged from the manufacturer or drawn up and labeled by the RN or pharmacist. Again, always good to have extra supplies just in case you drop something or something becomes contaminated. For continuous therapy, we're going to be obviously checking our orders every shift. Even if a patient has had IV fluid running for several days, you're still going to be checking the orders to make sure that that fluid hasn't changed. Also want to check for the rate to make sure that the rate is correct. So we've checked the orders, and again, checking the site for continuous IV therapy. Follow your facility policies, but a good rule of thumb is pretty much every hour that you're checking that. That includes not only the site, but just the tubing, make sure it's not kinked, make sure the flow, it's a correct rate. Some other things that we're going to be doing too that actually falls under tubing changes, but obviously prime the IV tubing before you hook it up to the patient. You want to make sure all that solution is in the tubing so you're not just injecting air. You're going to clean the hubs and ports every single time before you introduce anything, whether it's a flush or you change the tubing. And we're going to go over that in the skills lab. But not only are you cleaning the top of the hub with an alcohol wipe or whatever your facility uses, but you're also going to be cleaning the sides. A good quick twisting motion on the sides, on the top. So you want to rub it pretty vigorously, not just wipe it once. I probably over clean them, but I think that's a better rule of thumb. If, let's say, I've got 3 different medications that I have to push and I flush in between the medications, I'm going to be cleaning that every single time. before I hook something up to that IV tubing. And again, the labeling the tubing. So let's say you're coming on shift, you check the IV site, make sure it's the right solution hanging. I'm checking that the rate is set correct. I'm also going to eyeball the tubing. When was it last changed, or when was it initiated? Changing the dressing for peripheral IVs. Generally with this one, it's not going to be as it's not going to be like the PICC lines or the midlines where you have to use sterile technique. In the event that a dressing is starting to roll up or come loose, or the integrity of it has been compromised, those are all times when you need to change the dressing where you don't have to wait. Generally, it's every 7 days for a Tegaderm, the transparent covering that you're changing about every 7 days. But again, that might be a little bit different according to facility policy. Some facilities will have a policy that you change. It used to be, I think the old standard was you actually change your IV site, everything, the catheter and everything every 72 hours, regardless if it's a bad IV. But I think now that evidence has shown that if the IV is still working and the site looks good, just to keep it until it goes bad. So again, always consult with your facility policy on this. If you look on page 68 of your book, there's instructions right here of how to change a peripheral IV dressing, and we'll kind of be covering it as far as the procedures and your skills checklist as well. But obviously the most important thing is washing your hands. The book says to put on sterile gloves for that. Just see what your facility policy says, since it's not like the central line where you're using the sterile gloves and having a gown and mask on. Just make sure it's aseptic. Make sure that when you do go to, after you wash your hands, obviously you're going to have all your stuff right there in front of you because that IV is going to be in place. You're going to want to hold that catheter in place with your non-dominant hand just to prevent any movement or dislodgement of the catheter IV. Also be careful not to manipulate it too much. You're going to gently remove that tape and any of the dressing you have with that. The stat lock also is going to come off and be changed when you do your dressing changes. Definitely assess that venipuncture site for any signs of infection, including redness and tenderness, any infiltration, coolness or blanching or edema, thrombophlebitis, firmness or any bumps or pain along the path of the vein. If you do see those, definitely apply pressure to the area with the sterile gauze and just remove that catheter tip, and then go through your procedures for discontinuing and assessing that catheter and catheter tip. Apply pressure to that site until the bleeding stops, and then apply an adhesive bandage. If you don't detect any complications, hold the catheter at the hub and carefully clean around the site with an alcohol swab or other approved solution, working in a swiping motion to avoid introducing pathogens into the clean area. Again, we're letting the area dry on its own. If you put the Tegaderm on before the skin is dry, that Tegaderm is just going to fall right off. It's just going to slide off. And then after you put that tape on, re-secure the device. If you have a sat-lock device, put that on, or use tape according to what your facility policy is. Complications of IV therapy, we'll go over this, but we're also going to have Unit 6 is going to deal with complications. Again, infiltration and phlebitis are a huge one. Cellulitis if you get infection. Catheter dislodgement, the actual medical term for it is extravasation. You might have occlusion, maybe if the IV was locked off and you had a blood clot or some blood platelets kind of gathered at the front of that tip of the catheter and it kind of obstructed the flow. You might have some vein irritation or pain at the site, a severed or fractured catheter, and that's why it's so important that we are inspecting that catheter after we remove it, as well as a hematoma. That could happen just from trying, and let's say you nicked the vein, you weren't able to successfully put that catheter in. If you don't apply pressure, you might get a little area or hematoma at that site. Other complications would include a venous spasm, a vasovagal reaction. You don't want the patient to pass out. You can get thrombosis, thrombophlebitis, More damaging complications could include nerve, tendon, or ligament damage, air embolism. That one, we're also going to be extremely concerned about that with our PICC line dressing changes and manipulation, as well as with the midline with that, and possible allergic reaction. That is the end of Unit 4, Methods and Techniques for Peripheral IV Therapy.